So again, here are my conflicts. So I really want to talk about three things. I want to talk about critical level of bioburden, because there are some companies that are predicated still on this concept that I'm excited to talk about. The next is talking about biofilm impeding wound healing. And I think if you ask, so I presented a lecture about biofilm at the SAWC, and probably 75% of the people in the audience thought that that was an important element in wounds failing. And then I want to finish by talking about enzymatic debridement effectiveness. So do y'all think there's a critical level of I probably gave my point away. Do you think there's a critical level of bioburden that impedes wound healing? You don't have to raise your hand. So I think what's interesting is what we focus on is only the number of bacteria. We don't get any information about the virulence of bacteria, and we don't really include any information about our hosts. So now that we can do DNA sequencing, or genomics of the bacteria, you can get some information about the virulence of the bugs as well as their resistance patterns. So we usually take care of compromised hosts, people that have an impaired immune response, leukocyte dysfunction, they have neuropathy, so if they have infection or pain, it's blunted. They have micro and macrovascular disease that may be one of the contributing factors in their foot not being red and swollen and angry compared to a healthy control group. So I found this study. I was looking for what's the foundational piece that is, it's 10 to the 5th or 10 to the 6th bacteria that is the threshold for causing infection. So I found this paper from 1957 from Elk in the British Journal of Exploratory Pathology. And so they looked at 26 healthy volunteers. I think these were probably people trying to get into medical school or a residency program that volunteered for this. So they used coag-negative staph strains. They had 22 sensitive penicillin and 4 sensitive erythromycin. So it's 1957. Your antibiotic choice wasn't broad. So what they did was they did intradermal injections, superficial scratches that they infected, and they had an incision that was 10 by 4 millimeters. So, I mean, it'd be great to get this through an IRB. We're going to incise and make a wound and then infect it on people. Then they looked for a minimum pus-forming dose. It's the only time I've seen this in the literature, but I think we should use it. And they said it was, 2 to 8 times 10 to the 6 CFUs of staph. Then the next part of this was they soaked a silk suture in this antibiotic broth overnight and sutured people, and the people that pussed out, they only had 10 to the 3rd Staphylococcus CFUs. And in the paper it said, in spite of penicillin therapy, the lesions progressed to the size of an orange, caused fever, and took a week to resolve. And as you might imagine, this experiment can convincingly demonstrate the enhancing effect of a stitch, but led to great difficulty in finding further volunteers. So I think that's the earliest that I could find that someone put a quantification on what causes infection. And then, so in San Antonio, there's the Institute of Surgical Research. It still goes on. It's at Brooke Army Medical Center, and since we've been at war for 20 years, they've built there's more money in this technology. They have a tremendous burn institute and rehab institute. So Robeson wrote a lot about quantitative bacterial culture. So the first study was 50 wound skin grafts, 94% grafts healed if the cultures were less than 10 to the 5th. 19% if it was greater than 10 to the 5th. And then he looked at surgical closure, 93% of wounds healed if it was less than 10 to the 5th, no wounds healed if it was greater than 10 to the 5th. All right, so 10 to the 5th, that's it. But I don't think there are guys. I mean, these are 20-year-old healthy people, not my guy with man boobs. So this is another study that looked at bacterial count, CFUs, in people with and without infection after surgery. So this is surgical closure. So what they found was there really wasn't a significant difference until day 3, culturing the incision line. But all of the CFUs to get there, this is 10 to the 6th. It was much higher before there was infection. There's all these guys that had it early didn't get infected, even though their quantitative bacterial cultures were above, the accepted threshold. The best paper in this space is from Sue Gardner. So she's from Iowa State, because I think she had really excellent treatment. She looked at 77 people that had diabetic foot ulcers, 65 healed or 84% healed. 5 developed an infection, 5, which mirrors what's published by total contact cast literature. Heals wounds fast, really low rate of infection. And she said, she looked at bioburden diversity, microbial load, microbial diversity, the kind of pathogens. It was not associated with wound healing. It was best predicted by the standard things we talked about clinically for a long time. Ulcer duration, the depth of the wound, the surface area of the wound. Still, in the most recent studies looking at why people don't heal, these pathologies come out. And I think this really kind of supports what the Infectious Disease Society of America and International Working Group kind of suggest to people: don't culture wounds that don't have clinical signs of infection. So what's interesting is there's a point of care autofluorescent imaging device that hangs their hat on 10 to the 4 CFUs. All of the work in this space, there's not one of their papers that says this predicts healing. What they say it does is it predicts physician behavior. Well, it's a self-fulfilling prophecy. You get a red light, green light, and it's like, well, you should debride this wound more because it's more than 10 to the 4th. So, I mean, they have a CPT code. I mean, it's a very, as picky as the FDA is, this is, such a bizarre choice because there's no evidence that supports this. So anyway, how about biofilm? I mean, I think biofilm has been touted for the last 10 years, 15 years. So I usually ask people this: is this biofilm? So you have this wound in your clinic, you roll this slimy piece of tissue off of the wound, and underneath you have this beautiful bed. Is that biofilm? So in the nursing audience, everyone is like, yes, that's definitely biofilm. I can see it. You can't see biofilm. And it's one of the reasons why it's not reported very often, is because it's expensive to do. You have to have, there's a couple techniques: microscopy, fluorescent microscopy, non-focal microscopy. There's other DNA testing now, but it's not visual inspection. So, there's a lot of studies that report there's a high rate of biofilm in wounds. So this is a systematic review, and they suggested there's a large disparity in the translation of laboratory studies to clinical outcomes and using topical agents. And there's insufficient human in vivo evidence, and I'll show you some of that in just a second. The heterogeneity between study design in vitro and in vivo really limits the generalizability or even the usefulness of this. The primary outcomes in a lot of biofilm studies isn't that there's biofilm, we treated it, and now there's not biofilm. Many of the biofilm studies never measure biofilm. It's also like a great journal club, because then they conclude we were successful because we eliminated biofilm. They never measured it. So there's 2 RTCs, 284 patients that they included in this meta-analysis, and they said there's no difference in wound healing and there's no difference in infection if you get the biofilm treatment or not. This is one of so here are 4 RTCs that look at biofilm treatments. So they're all small studies except for this study. All of them conclude that there were significantly improved wound healing rates by disrupting the biofilm. None of them ever measured the biofilm before, during, or after the study. They all have the same conclusion. It's as if the company may have had something to do with them writing their results. It was like the classic thing where people write their results before they have their data. If biofilm impeded wound healing, why do 90% of people heal if I put them in a total contact cast? It doesn't disrupt biofilm. And if I put someone in a shoe, why is their wound healing 20 or 30%? It doesn't add to biofilm probably. So I really think this is it's a marketing piece. Actually, the FDA really doesn't like the whole biofilm shtick, and I think they've come down recently on some of the products that have biofilm claims with no biofilm measurements. So, you know, another piece that I think people believe in, they bite on, they buy expensive products, and the evidence is really, really quite poor. Now I'm going to finish talking about enzymatic debridement. I love this topic because none of the studies have good clinical outcomes. So 24 people in each group, one got enzymatic debridement, the other got moistened gauze. There's no difference between these groups at any time point. There's no difference from the beginning to the end. The company does within-group analysis and says, look, there's a difference from the beginning to the end when we used our product. So it's significant. Well, that's not the comparison. The comparison is there a difference between the product and moistened gauze at any time during this study? And there's not. So complete, I think, intentional misuse of analyzing the data because they were looking for a p-value. Same thing with this study. This is a study that Art Tallis was the PI on, or this, I guess it's the same study. Look, so they compare people that had a large, what is green? A large response. It's the same in both groups, 71% versus 67%. What they did was they analyzed these little in-between things that they, I think, were not clinically important. And then this study that looked at sharp debridement with enzymatic debriding agents or debridement alone, and there's no difference in wound area reduction, mean time to healing, or wound status score. So over really very, very little evidence that this relatively expensive product makes a difference in clinical outcomes, but lots of people believe it. And this is another one that Travis Motley was the PI on. This is one of the larger studies, looked at enzymatic debriding agents and a silver dressing, and showed really no difference in wound area reduction, mean time to healing, or infection. So let me go to the end. So I think, especially for those of us who are involved in education, it's really incumbent on us to look at evidence versus mythology, or what the drug rep is going to come and tell you and say, you know, look, there's a p-value that's less than 5%. There's no clear bioburden that impedes healing or improves the success of healing in people with diabetes. I think biofilm evidence is negative. I think the study designs are poor. And I think the same is true if you look at the enzymatic debriding data. So with that, I will finish and thank you for your attention.